See, every time I do a hard cataract, I'm so stressed out. I want to go to a place like this and relax for a couple of days. And I'd like to say that I have no financial interest in any of the products that I'm going to show you. Though I'll happily refer my hard cataracts to Dr. Shibu or Dr. Minumathan to manage. Because a couple of years ago, when I was sitting in my clinic and a patient like this walks in, I call these cataracts, I nickname them the Coca-Cola cataracts because they remind me of Coca-Cola bottles, just that brown, that red. And Dr. Kiki Mehta was my professor when I was doing my MS, used to call them the beetle cataracts because they have that sheen on their surface, a shiny sheen that indicates that they are really rock hard. But then I realized that if you're going to give multifocal lenses and premium lenses, and I realized the advantages of small incisions of 2.8 really outweigh the necessity of having to do small incision cataract surgery. So I sat down, thought, and evolved not necessarily a new technique, but evolved a technique by which I can successfully manage hard cataracts whenever they do come into my practice. And I realized that in order to defeat your adversary, you first need to understand him. All big battle strategies are revolve around understanding the enemy, and therefore I want you to understand the anatomy of the hard cataract. Basically, the hard cataract is not hard like porcelain. You drop porcelain, it breaks into 100 pieces. It is hard like a coconut. It is leathery. It is not brittle. Get that picture very clear, because this is going to help you a lot in the way you disassemble the nucleus. That's point number one. Point number two, a hard cataract is not one single mass. But the hard cataract has got this very clever and dubious combination of a central amorphous core that is actually powdery and a thick leathery epinucleus that's almost impossible to tear open. Now this combination, when they are taken alone, can be handled. But when they are in combination, they become a formidable impediment to any technique of phacoemulsification that you know. The thick, see what we normally do. What is the nucleus disassembly all about? It is like breaking the nucleus into smaller parts so we can eat it up. I mean, that's what we all been taught. But please remember that a thick leathery epinucleus cannot be broken across. In fact, I say that if you can crack the nucleus with your chopper into 2 bits, it's not a hard cataract at all. And in order to put my money where my mouth is, I'm going to actually show you some fantastic videos which Dr. Sivira gave me, in which he actually took out a dry nucleus out of the eye and dissected it. This is in a dehydrated state. Imagine how formidable it will look if it is hydrated. And you see the leathery epinucleus. As she uncovers it, you can see the amorphous core in the center. So this is the combination of this cataract. This is what you need to really understand. And to take it a little further, you look at this hard cataract and look at the phacotip. The outer diameter of this phacotip is 1 millimeter. And when you compare the diameter of this tip to the diameter of this nucleus, you can see what a big, hulking, huge and terribly frightening black nucleus this is. Now this particular vista should stay in your minds, because you need to understand that this probe needs to go to at least about 3/4 of the depth of the nucleus before you can actually start doing anything to it. Okay, this is the anatomy of the hard cataract I really want you to understand. And before you start handling hard cataracts, there are, along with your adversaries, there are the allies who make problems difficult for you. I'm going to show you a set of photographs, and they have 3 things in common. Okay? The first thing is, they're all photographs taken on the first post-operative day. The second is, they're all photographs taken on grade 4 to grade 5 cataracts. And the reason why there are only 4 is that there are only 4 cases in which I've really had clear corneas when I did hard cataracts. But before that, I had my learning, I had my striate keratopathy, I had my heart breaks, and this is what I think finally turns into knowledge. So I'm going to pass these heartbreaks to you so that you don't have to go through them yourself. Before you think of handling a hard cataract, devise a strategy. Okay? Because the man who plans will never fail. The strategy is, remember that you can have wound burn. Okay? Wound burn because you're going to use excess of cavitational energy. Remember that the corneal endothelium is not at all forgiving. It's extremely fragile. It's extremely susceptible to cavitational energy that you throw at it. Then remember that the zonules, when you're handling a normal cataract, which is a grade 2 or grade 3 cataracts, the zonules do not really take that much of stress and strain. But when you're doing a hard cataract, remember at any point of time, in the middle of the case, you may suddenly find that the zonules give way. And this should be, you should remember that. The posterior capsule in a hard cataract has a tendency to trampoline. Now the reason is because you saw the size of that nucleus which I showed you. The normal nucleus in a grade 2 cataract is 3 to 4 millimeters. In a hard cataract it's close to 9 millimeters. Now the entire back is so stretched that as you disassemble and remove pieces of the hard cataract, you find that the capsule is so stretched, it is thin and it tends to trampoline. And you will find that many of us catch it in the last, when we are trying to emulsify the last piece. So you need to tone down your parameters, especially the vacuum and the power, as you take more and more pieces out. And of course, there's always this question of cavitation. Now, these are the problems that I want you to remember, I want you to bear in mind. And this is the solution that I'm going to offer to the problems I just said. If in a preoperatively, when you're checking the patient, if the pupil does not dilate, or if there is zonular stability, refer this patient to your worst enemy. Or if you want to take it, remember if both exist together in the same patient, then don't do phacoemulsification. I think Dr. Minu would do it, but I would talk. This is about a few suggestions I'd like to make. A small pupil is not a problem now. We have hooks and rings that can take care of small pupils. But zonular stability, even with the CTRs and all that, is fine. But remember that you have to go through the heartache of taking out a hard cataract. The specular microscopy is important because it tells you the state of the corneal endothelium. If you have a poor endothelial cell count, then it is better, I feel, it's even better to do a ECC. ECC is even better than a small incision cataract surgery. Remember, do not do these patients under topical anesthesia, not because you're a bad surgeon, not because topical anesthesia does not work, but in case at any point in time you need to convert, you need to extend the incision, you find that the zonules have given way. So I always do a peribulbar anesthesia. I prefer a posterior limbal instead of a clear corneal incision because of the issue of wound burns. The posterior limbal has a better chance of healing, there's less amount of wound burns. Always stain the capsule. Now, I cannot emphasize the importance of staining the capsule when doing a rock hard cataract, because in all our endeavors to disassemble that nucleus and all the puffing and panting that we do, we sometimes forget what happens to the capsule. Many of them, if you lose the integrity of the rexus while handling the hard cataract, then the game is over. Then hydrodissection is an important step because you just can't allow the wave to go right through and lift up the nucleus like you would do in a softer cataract, because that would cause the posterior capsule to blow for two reasons. One is the posterior capsule is extremely stretched in a hard cataract because of the bulk of the nucleus, and second is it's also thinner. So you do a multi-point hydrodissection. I'll show all of this in a video. And finally, remember, when you talk to the patient with a hard cataract, you always address plan B. You tell them that on the table I may change my technique. It will save your face. Okay, my mantras for handling a hard cataract: power modulation. I mean, the reason why I'm able to do hard cataracts today, without losing my sleep overnight, and I'm also ending up looking at reasonably clear corneas the next day, is because of power modulation. And there's only one power modulation I want you to know, and that is called the burst mode. The burst mode is the single most important thing that you need to have, because the minute you go into position 3, 100% of a preset power is delivered. It is delivered in packets which are manageable. Means you can have packets as small as 30 milliseconds to as much as 500 milliseconds. And you can control, depending on the excursion of your foot pedal, the time interval in which these packets are delivered. So you have absolute control over every parameter of phaco in what is called in the multi-burst mode, which is what I would do and what I would recommend for hard cataracts. The second important thing is the ocular viscosurgical devices. And remember that sodium hyaluronate is the worst agent that you can use in hard cataracts. Sodium hyaluronate is a cohesive viscoelastic which tends to sit and maintain and deepen the chamber, but the minute you put in your phaco tip, within 2 to 3 seconds the entire viscoelastic is out. Sodium hyaluronate, while I'm talking I might as well show you a video. Sodium hyaluronate also has only one negative charge versus chondroitin sulfate that has 3 negative charges. These negative charges increase the affinity and the ability of the viscoelastic to attach to the corneal endothelium. So this is the substance I really use. I don't use the soft shell technique. I use, this is a video of Disco Visc, but I use Viscoat, which is a combination of sodium hyaluronate and chondroitin sulfate, and it's a single solution. You don't have to really worry about which to put first, which to put second. The 3 negative charges that are present in chondroitin sulfate coats the endothelium and protects it. Remember, a rule of the thumb, if you're doing hard cataracts, for every quadrant that you remove, you need to come out and put in viscoelastic, and that is imperative. And the chopper is my biggest friend. It's my second instrument, and it is my right hand. I'm sorry, it is my left hand because I operate with my right hand. So the chopper, I feel that you need the right tools for the right job. The chopper I use, which I'm going to show you, many of my students have looked at it and fainted because it is called the combo chopper. It looks like a stiletto. It is long, it is sharp, and it's pointed, and it does the job. Okay, so that's the chopper. And the technique, I'm going to tell you one technique. It's actually, bottling old wine in a new bottle, because I've heard this from many other people, but I call it this because this is what I actually do. I call it the wood flower technique of taking out the hard cataract, which is what I'm going to show you. Let's see these videos now. Enough of hearing me talk. You can see that this is a really hard cataract. This is a grade 4 cataract. I stain the capsule like I told you, and this is the multi-point hydrodissection that I do. I inject small aliquots of fluid at different zones. I don't wait for the nucleus to rise, and that was Viscoat. So in the wood flower technique, okay, I'm just going to have to show what the wood flower technique is all about. Then you will understand the video better. Okay, the wood flower technique consists of 3 parts. I call the bloom, where I make multiple chops onto the nucleus. None of them extend through and through because they cannot extend through and through. And when you make multiple chops, you can actually open out the nucleus like a flower. Okay, that's point number 1. Secondly, coring, I eat the amorphous core. I actually dislocate the amorphous core after opening it up and eat it up. That's point number 2. The third is, since I don't have a through and through crack, I hold each of the petals, I bring it out. The nucleus at this stage is still in the bag. It's not popped out. It cannot pop out. It's too large to pop out. So I catch each of the petals, bring it to the center and nip it. So finally you end up with a small leathery plate which you can rotate and eat. Okay? Now this is what I'm going to show you in the video. This is exactly what I'm going to show you. So just fast forward it a bit. Okay, now you see that I'm doing the multiple partial chops. They don't go through and through. But as I chop, I'm able to expose the amorphous core. The idea of making these multiple small chops is to expose the amorphous core. The settings are the multiburst mode. I have a power of just 40%. Unbelievable, but it's true. I use a burst duration of 30 milliseconds, and I use a vacuum of 200 in a dual burst in a dual linear foot pedal. I use the Stellaris machine, and you see that as I make these multiple chops, the amorphous core starts becoming visible. That's the amorphous core, which I would just prise out. I take it out. Okay, now half the battle is won. Now once you've taken this amorphous core, you weakened your adversary considerably. It's only the leathery epinucleus that you have to take out. You've taken out the nucleus. I mean the heart of the nucleus. Now this leathery epinucleus, it's impossible to effect a through and through chop that runs all across. So I just lift it up and I just eat up. This is called nipping the petals. Because you can't completely break it. It will be, many times I find that it is connected to the base, in some way or the other. You cannot effect a complete through and through chop. For every quadrant that I remove, I go in and put in viscoelastic. Even if you think that you can finish the surgery, you have to be cognizant and aware that for every time you remove one quadrant, you go in and you put in not any viscoelastic. Sodium hyaluronate is total waste, and methyl cellulose is not even a viscoelastic. So you have to use some viscoelastic that has chondroitin sulfate, because of the fact that the negative charges on the chondroitin sulfate has an affinity to stick to the corneal endothelium. And then you find that as you nip up everything, you're finally left with that leathery final plate which you can eat up. And this is the picture of the same patient within 24 hours. Of course, there is a little escape. So my trip to the Bahamas got cancelled, but still the patient was largely clear. So with this, I'd like to say that I have realized that no rock is so hard that the human spirit cannot surmount, and no rock is so solid that the human will cannot pulverize. So if you pay attention to details, then you can take out the hard cataract, which I think is the final frontier in that transition of a phacosurgeon from a novice stage to that of an expert. Thank you very much.